What I'd like to do today is review some of the factors of increasing maternal mortality and morbidity in the United States. I think we need to turn the volume down just a fraction and discuss the current work of our Kentucky Maternal Mortality Review Program and then some of the developing standard methods for national surveillance of maternal mortality. Now, you can't really start a lecture on maternal mortality and not refer to Semmelweis. So Semmelweis made this comment: it's not by chance that a single obstetrician has 16 fatal cases in a single month. I can only dispel the sadness which falls upon me by gazing into the happy future when the infection will be banished. So Semmelweis was the chief of obstetrics in the Vienna Lion Hospital. And at that time, they had two clinics. They had the resident clinic where doctors would do autopsies and then come do deliveries. And then they had the second clinic, which was staffed by the nurse midwives. So Semmelweis looked at the mortality. And the important thing here, we use mortality now as 1 per 100,000. In Semmelweis's time, it was 1 per 100. So the mortality in the first clinic was 16%, and in the second clinic was 7%. And he noticed that the residents came from the autopsy suite and their hands smelled like the corpses, whereas the midwives were coming in off the street wearing their white gloves and had nice smelling hands. So again, this was 20 years before germ theory, before Lister and Pasteur. So he thought, well, there's something about the smell, so we need to clean their hands with chlorinated lime, and in doing so, markedly reduce the risk of death down to 2%. Now, it's interesting, the patients knew this. So if you were a patient and you knew it was clinic day 1, you knew that it was safer for you to deliver on the street than to go in the hospital. So that, even 200 years ago, street people and prostitutes knew, stay away from the residents. So, this is a quote that I have. Newspapers, magazines, medical journals, and speakers throughout the entire country have for many years been focusing the attention of the people on the excessive maternal mortality in the United States. Now, this could be a quote from our past president of ACOG, Lisa Ollier. No, it's not. It could be a quote that I made this year as chairman of the Mortality Committee. It's not. It's actually from 1937. I was doing some research recently on the history of the treatment of eclampsia. So this has been a problem for years in the United States. This is not something that's new to our decade. So looking back in 1950, in an article in JAMA, we reduced maternal mortality down to 1 in 1,000. And at that point, it was said, this is as far as we can get it down. We've reached the nadir of maternal mortality. But in actuality, over the next several years, we were actually able to reduce it even more. But then around the late 1980s, we started to increase again. You can see we'd gotten down to around 10 per 100,000. But we've been creeping up ever since. And particularly the concern is there's racial disparities in maternal mortality. For Caucasian women, about 12 per 100,000. Again, we're using per 100,000, not per 100. But for black women, 3 to 4 times higher, 43.5. Hispanic, about the same as white women. When we look at this from an international standpoint, we're really doing poorly compared to the rest of the world. Italy, Japan, 4 or 5 per 100,000. Even if you look at only white women in the United States, we're one of the highest risks for maternal mortality of all the developed countries. And even in our own state, the numbers are pretty staggering. We're 42nd out of the 50 states as far as maternal mortality. And the most recent data we have is for 2018. So far, we're looking at a rate of 140 per 100,000. Now, so the United States is 47th in the world behind other developed countries, clearly much higher risk for women of color compared to white women. And traditionally, we focused on the big three: hemorrhage, hypertension, and infection. But something is changing, and that's why it's important for these committees to address this. So there are disasters out there waiting to happen. So what really has changed in the last few years that's causing this increase in maternal mortality? Well, number one is maternal age. Women are, even though the birth rate in the United States is decreasing, women over 35 is one of the fastest increasing groups. There was a couple in India earlier this year. She was 72, he was 84, that got pregnant with IVF. Now, I don't know that I'd want to be 98 years old teaching my teenager how to drive, but that's their choice. They did it through IVF. But again, when you look at the data, overall birth rate is decreasing, but for the subsets 30 to 34, 35 to 39, and particularly 40 and greater, a greater incidence in pregnancy. And these women carry with them greater risk for underlying medical disorders: hypertension, diabetes, cardiomyopathy. And they also carry a greater risk for mortality. You can see in this graph from out to age 30, the maternal mortality is fairly similar. But once you hit 35, it really skyrockets from these underlying medical issues. When you actually look at the data and break it down, what's so unique about these women over 35? Well, slightly higher risk for smoking, clearly a higher risk for inadequate antenatal care, underlying comorbidities, medical comorbidities, an odds ratio of almost 6, and then previous pregnancy complications. Obesity is clearly increasing. In 1985, we only had 2 or 3 colors on our map of a BMI greater than 30, which would be the definition of obesity. By 2014, we're almost running out of colors. We've expanded so much. Kentucky is right in the heart of obesity. And clearly, as obesity goes up, medical complications go up and risk for maternal mortality goes up. But the big thing I think that we're seeing in Kentucky is the opioid crisis. When you look at, this is a really nice article from The Economist back early in February. When you look at the number of opioid deaths, very minimal around 1999, but gradually increased with prescription opioids, particularly with fentanyl and synthetic opioids and heroin, although the change with methadone is fairly stable over that time period. And then the overall overdose death clearly increased in the past 30 years. And then one interesting graph they had is how things have changed 1999 to 2003, looking at prescription opioids, Kentucky, particularly Appalachia, and then some of the Indian reservations out in the Southwest. But then by 2012 to 2016, the whole country is essentially covered by a high problem with prescription opioids. Heroin, essentially unheard of early on, now a very big problem, particularly through Kentucky and Ohio. And then fentanyl and synthetic opioids are a fairly similar story. And in our own state, we really had not done a lot of focus in the maternal mortality on opioid-related deaths. That's one of the new, with the new paradigm. But over 50% of our maternal deaths in the last 3 to 4 years have been related to opioids. And particularly what we're seeing is postpartum deaths from the opioids. Women during pregnancy are under surveillance. We're doing random drug screens. They know that if they have a positive drug screen, they're not going to be able to take their child home with them. So we do a good job while they're pregnant, but where we're falling off is that 6 week to 3 months after the delivery. So we have greater underlying medical complications in our pregnant population now. More pregestational diabetes, more chronic hypertension, renal complications, particularly renal transplants, complicated lupus, and then underlying cardiopulmonary diseases, congenital heart defects that 30 years ago would never live long enough to be pregnant, now are pregnant with their underlying cardiac problems. Cardiomyopathy, particularly increasing with the increasing maternal age. Cystic fibrosis, 30 years ago, we didn't worry about pregnant women being, a cystic fibrosis woman being pregnant because they didn't live long enough to get pregnant. Now, with modern therapy, women with cystic fibrosis can live into the 40s and 50s. And then pulmonary hypertension, again, something we didn't worry about because they were dying, are now surviving and wanting to become pregnant. Physician's Guide for Rare Diseases. You know, we see patients all the time now that come in with these diseases that you never would have thought of worrying about having them pregnant. But again, they're surviving with our increasing surveillance and medical therapy such that they can get pregnant, but carry a significant risk for mortality and morbidity. The other thing that's changed is our obstetrical practice. Clearly, the rate of cesarean delivery has increased, and unfortunately, with cesarean deliveries, you run a higher risk for infection, a higher risk for hemorrhage, and therefore a higher risk for mortality. We're seeing a marked decrease in operative vaginal deliveries, and it's essentially a near extinction of vaginal breaches now. Essentially, if you have a vaginal breach and it's a singleton, you're almost committed to cesarean delivery. And then we have changes in practices as well. We're using the laborist model, and there are more handoffs. And with handoffs, you run the risk for information is not conveyed to the next group that's caring for that patient, and that runs the risk for complications. And then we're increasing reliance on other medical subspecialties for the treatment of hypertension or diabetes. It's not just the obstetricians that know these patients and are managing these patients. We're bringing in more people to help in the management. But as we do that, there can be loss of information. So looking at this from an international standpoint, we're not alone in the United States that we're lacking some of the data. 88 countries lack complete data, 27 countries have no data, and 65 have complete. But about 80% of all births that occur in countries where maternal cause of death data don't exist or are incomplete. And that's one of the goals that we have here, and one of the goals that Dr. Ollier has really pushed for when she was president is improving our surveillance to make a difference in reducing maternal mortality and morbidity. So what are some of the problems? It comes down to the reliability of our data. You know, we've focused a lot on death certificates, but not very accurate. I know one of the reviews I did a couple of years ago on a maternal death, I went and reviewed the record. She'd had a hysterectomy 3 years before, supposedly she had a maternal death. Well, I never could quite figure out how that happened. I'm just a stupid obstetrician, but I do know that you need to have a uterus to have a baby. A lot of this is based on ICD-9 codes, hospital discharge data. And the thing is, if you actually review the record versus just looking at the data that's supplied in the record, about half the time it's incorrect. And the other thing that's different is our definition. The WHO definition of maternal mortality is 42 days from the birth, whereas in the United States we're using 1 year. So that's going to make our numbers look worse than the rest of the world. And then again, what's a maternal death? Is it a direct death? Is it an indirect death? Is it coincidental? And these are some of the differences why we don't look as good compared to some of the other developed countries across the world. So this was a news thing that came out. Texas has the highest maternal mortality rate in the developed world. I'm not hammering on you, Lisa, sorry. But what happened, and this is the problem, they introduced an electronic death certificate. Didn't teach anybody about it. There was no, here's what you do. And it was a drop-down box. It was either yes or no. And when actually they went back and they didn't do any sort of review. When they actually went back and did the review, they had one of the lowest maternal mortality rates in the United States. They found multiple patients that were listed as maternal deaths that were in their 70s or 80s or had not been pregnant for 10 or 20 years. So again, we have to have some validation of who actually is a maternal death. And that's the benefit of our committee now, is that we're reviewing these individually to prove, one, were they actually pregnant within a year, and to kind of come up with a decision of was the death preventable or not preventable. So there has to be some review as we're doing these surveillances. So again, the other thing is we're much less likely now to have autopsies. They're expensive. They're really probably not as thorough as they should be. So you have this issue of the clinical impression, what do I think she died of, versus the autopsy. And unfortunately, a lot of our death certificates, she died of cardiopulmonary arrest. Well, I hope she is with cardiopulmonary arrest, but because she's dead, but that really doesn't really help us as far as what the underlying etiology is. And the other problem we have is there's so much overlap when we have a maternal mortality. If you have preeclampsia and hemorrhage and sepsis, then what's the primary cause of death? It could be any of those three. And then you have overlap like amniotic fluid embolism, which is going to be associated with DIC. But what if it was postpartum hemorrhage or eclampsia that also had DIC? So it becomes difficult in actually focusing in on what was the actual cause of death to see, can we make a difference in our further care. So as was noted, a legislative mandate in April of 2017, which authorized the Kentucky Department of Public Health to have a Kentucky Maternal Mortality Committee. And most importantly, and this is the thing that really hindered us over the last 10 years, is that previously all of our proceedings were open to discovery. So what happens was we had to say, well, we had a reproductive age woman that died of blank. Whereas now that it's not open to discovery, we can dive deeper into that. How old was she? What was her BMI? What were some identifying factors for that woman that can help us to try to reduce this mortality in the future? So the definition of maternal death through the state, a female between the ages of 15 and 55 that was pregnant within 1 year prior to the death or pregnant at the time of death and died from any cause. And again, the death could be any cause, and we're doing Kentucky residents only. So our process is we identify these cases. This is done two ways. One, through the death certificate, because there's a box to check, were you pregnant, was the person pregnant within the past year? But also looking at women of reproductive age that die, that we can, attack that. And then information directly provided to the committee. If I know of a patient that has a maternal death, letting us know to make sure she doesn't fall through the cracks. And then once we identify those cases, the cases are abstracted, reviewed as a committee, and then we come up with what we think was the actual cause of death and whether that's a direct or indirect, and whether we can make some changes in our care to reduce the likelihood of this happening again. So the vision of the Maternal Mortality Committee is to eliminate preventable maternal deaths, reduce maternal morbidities, and improve population health for women of reproductive age in Kentucky. That's our goal. The problem, mistakes were made, not by me. That's what everybody always says. So it's very important that this is a confidential procedure, and we've been helped by the legislative mandate that it's not discoverable. So these records are de-identified. All of the committee members signed a confidentiality agreement that we will keep this information confidential. It's not to be used for litigation or punitive action, and we're not blaming people. We're trying to collect data. We're trying to improve our process and our outcomes. So by the CDC, a death is considered preventable if the committee determines that there is at least some chance that the death could be averted. And there's a variety of different ways we're going to look at this. First of all is the patient. Was there some lack of adherence to medications or treatment that was associated with the death? Any abusive relationships or unstable housing, something from a social standpoint that could have improved or reduced the risk for the maternal death. Do we have adequate support systems for these patients, or lack of insight into a high-risk patient? Did we not realize that some medical complication was putting her at risk? And were there warning signs of these underlying medical problems that were ignored? And then we have from the provider standpoint, was an appropriate assessment with screening or assessment done? Was the treatment that they provided ineffective? Was there some lack of communication between the providers? And again, I go back to these handoffs. As we have more shift work in obstetrics, we have more handoffs. Is there good information being provided from one shift to the next shift, from a physician standpoint, from a midwife standpoint, from a nursing standpoint, of what the underlying problems are, so that can be conveyed on to the next shift? And then communication between the provider and the family. And then from other preventable factors, from a facility standpoint, do we have adequate assessment of the risk for the patient? And from a community standpoint, are services available? And particularly, this is important with our substance abuse problem. Do we have adequate counseling and support for these patients that have issues with substance abuse? And then lastly, systemic factors. Coordination of care, support of personnel, and then do we have policies and procedures, particularly our bundles for hypertension, for sepsis, to improve outcomes. So it's a continuum. You don't essentially just go from well to dead. There's some continuum in there. And the key is, can we identify some conditions that are predisposing these women to a higher risk for maternal death? Certainly for hypertension and preeclampsia, if we can pick up the hypertension earlier, treat the hypertension aggressively, proceed on with delivery for these women, we may be able to make a benefit there. Clearly they're at risk for complications like pulmonary edema, abruption, but the earlier the diagnosis, the earlier the intervention, hopefully we can avoid that mortality. But the same can be said for hemorrhage, less so for embolization, and certainly for sepsis. You know, the golden hour in sepsis is really that first hour. Can we make the diagnosis? Can we get our fluids going? Can we treat with the antibiotics? And early intervention can clearly make a difference for these patients. So what have we learned so far? Looking at hemorrhagic death, this is from CDC data, probably 93% of deaths were potentially preventable. But the key tends to be not realizing or appreciating the extent of hemorrhage that's going on, and failure to restore blood volume. And I always make a point to the residents, you need blood to have blood pressure. And there's this push that you don't want to give blood because you're going to get dinged if you give more than 4 units. Well, you're going to get really dinged if the person dies because you didn't give the blood. But I make the point, particularly in abruption, that not only is blood life-saving, it's kidney-saving. So when somebody abrupts, not giving them blood underperfuses their kidneys, so even if they survive, they may survive with underlying acute tubular necrosis, or even worse, acute cortical necrosis. So we have bundles that are helpful for this. But more importantly is drilling, to go through the hemorrhage drill, and involving not just the obstetricians, but anesthesia and blood bank and nursing, to know how does blood get from, how do you order the blood, and then how does blood from the blood bank actually get to delivered to the patient. We did this in our own hospital and found out the typical way for blood to be delivered is it's tubed up. We found out that if somebody runs over to the blood bank and comes back, we can get the blood 10 minutes faster. And when somebody has an accreta or somebody has an abruption, that 10 minutes can be kidney saving, potentially life saving. So I think these are important things to use with your drill. Having O-negative blood available, having some organized response team when you don't anticipate this blood loss. And then the other thing is, you know, we're seeing a much higher risk for the morbidly adherent placenta now. It used to be 1 in 5,000, now it's 1 in 500. So early identification for these patients, early delivery in a controlled situation is improving outcome. What doesn't work? There was a push for putting in uterine artery stents that you could occlude the uterine arteries to reduce your blood supply. But the thing is, all the blood mixes around. That's one of the things I learned in medical school. Blood mixes around. But the thing is, when you put these stents in, you're just pushing the blood someplace else. It's still there. And I really think that most of the data now with the morbidly adherent placenta, the stents are not that helpful. The key is not really appreciating that loss of blood. I mean, the perfect example, we had a patient brought in a couple of weeks ago by EMS. The bed was, the stretcher was completely covered with blood. After she delivered with an abruption, it looked like they'd slaughtered an animal in the room. We drew a crit, the crit came back 30. And I asked everybody in the room, I've ordered 4 units of blood, the crit's 30, do we give the blood? And everybody said, well, no, the crit's 30. Wrong. Look at the floor, look at the clinical situation. So we still gave her 4 units of blood and her crit the next morning was 21. So your labs are always going to be a bit delayed for what, use your clinical acumen. And giving crystalloids when you really need blood. Crystalloids are fine acutely, but you've got to restore that volume. And then the other thing is delayed operative response. If somebody needs an operative intervention for uterine artery ligation or a B-Lynch or a hysterectomy, delaying can be increasing mortality. And then what about hypertension? And probably 60% of maternal deaths are potentially preventable. And I think a lot of this comes down to not controlling blood pressure, not recognizing HELP syndrome, particularly when patients complain of the epigastric pain and they get treated with antacids or Tums or something. But it's telling you you've got to think about HELP syndrome, pulmonary edema, and then particularly these patients that are coming back to the emergency room a week later, 2 weeks later. Most ER physicians, well, I'll not say most, some ER physicians feel that preeclampsia is cured with delivery. And we know that that's not true. And when they come back and they have severe hypertension or they have symptoms, they need to be treated aggressively with antihypertensives and magnesium. And that's one of our goals is to try to increase the awareness of that even though delivery will ultimately cure preeclampsia, it's not an immediate cure. And I think one of the things, again, this was from the committee opinion that came out in February on treatment of hypertension in pregnancy, is the response, how quickly we're getting this blood pressure down. And this was a study published actually last year looking at how many patients that have severe range blood pressure, 160 over 110, actually get treated within that hour that's recommended. And then this was pre and post education about this. And you can see that it clearly made a difference after we implemented a bundle on how we're going to intervene and how we're going to treat. So really, if the blood pressure is elevated, the goal is make sure the patient's positioned properly, make sure the blood pressure was done properly, repeat it. If it's still elevated, order your drug. Get the drug to the bedside, repeat the blood pressure. If the blood pressure is still elevated, then treat. Now, what about sepsis? We know that the longer that you delay initiation of antibiotics, the greater the risk you're going to die for sepsis. And so really the goal should be, I want antibiotics started within 1 hour when I make the diagnosis. Because the longer you wait, the greater the risk for mortality. So the problem with all this is that most of these patients are dying at a time remote from when we have them under our observation in the hospital. So 2/3 of maternal deaths occur outside the week of birth, whether that's well before delivery or remote from delivery. So I think we can potentially do a good job of those patients in the hospital, but what about these others? And that's where some of these interventions like we're going to talk about today can make a difference. California started their CQI, I think it was back in the early 2000s, but you can see their data for their mortality rate clearly has dropped compared to the rest of the country because they've been extremely aggressive with their bundles for hypertension, for hemorrhage, for sepsis, and reviewing their data and acting upon that. So that really should be the standard for all the states because they've shown such a benefit. So, and all of this starts with better data. You know, and again, just relying on the death certificates is not going to help. We want data that can allow us to have better interventions and programs so we can monitor to know what the actual maternal mortality would be, and then by doing that we can improve maternal health. Now again, I give great kudos to Dr. Ollier for this, but we were able, through ACOG, through the Preeclampsia Foundation, we have one of their representatives here today, but a national agenda on maternal mortality. So this bill was passed and signed in December of last year to strengthen all the efforts of the states to prevent maternal deaths and promote information sharing throughout the different states. So in the past, we've done a very good job from a perinatal standpoint with our Group B strep protocols, our steroid protocols, PROM, magnesium sulfate, but we've not really done the same thing from a maternal standpoint. And that's certainly going to be our goal. So what have we learned so far? In these last couple slides, I just want to talk about what have we learned in the 1 year, or actually less, from the Maternal Mortality Committee from Kentucky. Drugs, opioids are a huge problem for us. If 50% of our women are dying from opioids, we've got to do a better job with this. And I think, you know, every patient needs a Casper to find out where are they on some opioids that we don't know about and they're not telling us. And then the other thing is our practice for prescribing these opioids. A woman that has a vaginal delivery with no lacerations doesn't need 50 OxyContin. We've been seeing this. You know, do they need some pain medication? Yes. It's not fair not to give someone that's had a procedure pain medication, but do we need to give 50 to everybody? And I think we need to back off on what we give, or look at what they required when they were in the hospital to have some scientific rationale for what we're going to give and treat. Distribution of Narcan kits, so that if these patients are abusing narcotics, that we have a way to rescue them, particularly if they're using heroin or fentanyl. Now, I always make the point that most drug dealers don't have a PhD in organic chemistry. So, you know, again, they're mixing this stuff up, and you'll hear that somebody died because they got a bad batch of fentanyl. Well, they got a great batch of fentanyl. And again, if they're saying, I'm going to use this much, and that much has carfentanil in it rather than fentanyl, that's when they're done. But if we have widespread use of these Narcan kits, maybe we can reverse this and save some of these women. Routine use of urine drug screens. I often hear, well, my patients don't use drugs. Well, that's crap. I think whether you're taking care of indigent patients or the wealthiest patients, it's out there, and it needs to be screened for and addressed. And then if we do determine that drug screens are positive, to test the cord blood or meconium to find out what the risks of that newborn for neonatal abstinence would be. From a perinatal period, coordination of care between the disciplines, particularly if these women have underlying medical problems like hypertension and diabetes. And then the access to prenatal care. And as far as the postpartum period, really pushing for increased attendance to the postpartum visit. Some of this has fallen off because we're doing pap smears every 3 years instead of 1 year. So patients aren't coming back. But expansion of presumed eligibility, some postpartum visit, looking for problems with substance, watching for hypertension closely. But from a safety standpoint, there are well-published bundles now for hypertension, for thromboembolic events, for hemorrhage, for sepsis. We need to use these. And I used to make the point that protocols were for idiots, but really protocols are for rare events. if you're going to see 7 cases of sepsis a day, you probably don't need a protocol. You know it well enough. If you're going to see 1 or 2 per year, you need a protocol to remind you, what do I do, when do I do it, what's the order, how much fluids do I give, and it's really for safety. And then just basic things, use of seat belts, and the correct use of seat belts in pregnancy. And then fire evacuation plans. We'll have 2 or 3 maternal deaths a year where patients died in a home fire because they didn't have an adequate escape plan or smoke alarms. And lastly, I'd like to thank, mostly like to thank Dr. Connie White, because she's done a great job of really pushing for the Maternal Mortality Committee to be more of a scientific review of these maternal deaths so that we can maybe make a difference in the state, and then her team at the state. If you have maternal mortalities, you can call us. We're not going to turn you in. We're not going to be calling the lawyers the next thing. But we want to have good data so that we can make a difference for these women and hopefully reduce our maternal mortality, which I consider right now, it's not as bad as Semmelweis, but it's certainly higher than it needs to be. Okay, thank you very much.